Hello, everybody. Welcome. So exciting to have you with us today. And we are so thrilled to have with us Dr. Desiree Chow, who is a primary care doctor, the Associate Medical Director of our General Medical Associates, our primary care practice here. She's somebody that the residents love to work with. And she's a great doctor who, when people call and ask, like, who should my colleague see? Who should my relative see? I don't even know if you know this, Dr. Chow, but everybody says you. And so it is a particular thrill to get to talk to you a little bit about, we're both primary care doctors, and I love talking about primary care. Maybe we should start like at the very beginning. Like, when you think about primary care, like, what does that even mean?
Well, first of all, thank you for having me on to discuss my favorite field of medicine. Isn't
it everybody's favorite field of medicine?
It should be. It really should be. And so thinking about what primary care is, many people have tried to define it. The Institute of Medicine defines it as a provision of accessible, integrated healthcare that's provided by clinicians that oversee the majority of health problems in the context of community and family. And so I think, with all the different definitions, they really put the emphasis on care over time, longitudinal care, care in the context of a community, and really overseeing a lot of different medical health needs. This can be provided by family practitioners, internal medicine trained doctors, pediatricians, general pediatricians, and even OBGYNs can provide primary care.
And when I think about the scope of primary care, like, I really think about, and this is a lot of the work that you do too, not just that sort of like one-on-one interaction in the office, but also a kind of like broader look at population health and sort of dealing with the communities. What is, people sort of understand what the doctor-patient relationship is in the exam room, but what's that kind of broader stuff that you do?
Right. So yes, it is taking care of the population around you, so your community. The National Academies of Sciences, Engineering, and Medicine actually updated that definition that I just told you about to state that primary care is really the care of the whole person, whole people, by teams of providers, not just one, doctor, patient, but a whole bunch of people involved in the team, taking care of the population, essentially.
Yeah. So when I moved to New York about 20 years ago, I was shocked to find out that lots of people here didn't have primary care doctors. And people felt like, oh, I have a cough, I go see the pulmonologist. I have a pain in my chest, I go see the cardiologist. But you and I both know that there's lots of benefit in having a primary care doctor. Maybe that's something, I know there's some data out there on that, right?
For sure, there's lots of data they've done studies dating back to the 1980s, looking at the benefits of primary care, and studies after studies show that the supply of primary care, which is defined as primary care per 10,000 of the population, if the supply goes up, that multiple outcomes get better. So outcomes as broad as all-cause mortality. So death from any cause goes down, cancer-related deaths, heart disease-related deaths, all go down when you increase the supply of primary care. So there's definitely benefit.
Right, and I think about that, increasing the supply of PCPs, again, it's like not just because then there's more opportunity for people in the office to have those one-on-one interactions, but all of a sudden you're able to like take care of the people who aren't in the office, like all the people in the community. Oh, I haven't seen them in a while, or they show up to the emergency room with some acute illness, and we can kind of grab them and make sure all their preventive care stuff is done. So it really does feel like there's stuff that primary care docs are paying attention to that's like really important for those outcomes in general.
So there's a great piece by Atul Gawande. I think it was in 2017 in the New Yorker, and it was titled "The Heroism of Incremental Care." And the reason why I love it is that it really highlights the importance of longitudinal care. It talks about that developing that, or how important that patient-doctor relationship is, and that's why primary care is an important field to have. He even alludes to all the different benefits that primary care has in terms of decreasing mortality, increasing lifespan, and one of the biggest drivers or it seems like one of the drivers of why having primary care doctors or increasing the supply of primary care doctors decreases mortality is because patients who have primary care doctors and doctors that they have a relationship with are more willing to seek out care for symptoms that they're having, whereas somebody who doesn't have that relationship might just sort of deal with it until it becomes something that they need to go to the emergency room for, and then it's too late.
That's so interesting. So, okay, so suppose somebody wants to find a primary care doctor. I'm a doctor and I find it really hard to figure out who a good doctor is. Like when people ask you for advice around picking a primary care doctor, any kind of doctor maybe, what kind of advice do you give them?
Well, I definitely have personal recommendations because of all the great doctors that I know, but I think if someone out there is looking for a primary care doctor, a good place to start is really just looking within your network. So your health insurance plan typically will have doctors within the network that you want to start off with. And the reason why you want to start there is because then it's covered, what your costs are going to be. And then from there are different factors. I would say proximity is important. So again, when I said before, the definition of primary care includes, sort of your community, it's important to have a doctor, I think, that knows where you live, what your community is like. And it's important to have somebody who's easy to get to. So either, someone that's close to home or work, so that when you need to get care, you don't have to travel 20 miles to get to them. Other things to factor in that I think are important are how your doctor communicates, or how not just your doctor, I should say the team and the office communicates with you. And so, if you prefer electronic communication, does that practice do that? Do they have a portal where you can send a message to the team if you have a question? Or if you prefer, phone, how accessible is that office over phone?
So, I feel like I learned over time how important that geography piece is. I remember in my first job out, I used to ask every patient was new to me, and I asked everybody how they found me, and I was expecting people to say stuff about me, but almost everybody picked me because of geography and insurance, and I think I sort of underestimated how important those things are.
Yeah, definitely. We still do have in our practice people who travel fairly far, but it is difficult, when they have an acute need, and sometimes you will have an acute need and you want to seek care from your primary doctor, that travel isn't great. Now more than ever, we've really delved into telehealth and telemedicine, and so that sort of helped within that situation. But still, I think having a doctor that's in close proximity is a good idea.
Yeah, right. I do feel like things have changed over the last couple of years, I guess, even before the pandemic, where I might see somebody once, and then I've got 2 years of my chart messages and, video visits and forms and stuff before I might see them again in person. Do you have that same experience? How do you balance when you need to see someone in person and when, when all those sort of side conversations are appropriate.
Yeah, I mean, I think, and I love that we have that, that capability of being able to communicate with our patients without a face-to-face visit. Although I do think face-to-face visits are important.
Sure.
But, primary care is, again, all about developing that relationship. And so, for me, I think if it's something easy that I can handle over just a MyChart message or a patient portal message, that's great. If it's a new complaint, and we've really never discussed it before, then typically I will have patients come in to the office so that I can really, get a good idea of what's going on.
Yeah. So, okay. So somebody asks you for advice, you give them advice, they pick a primary care doctor. Can you talk about like how often they should come in and see that person and what happens, when they're there? How do you sort of decide what testing and stuff to do?
Yeah, so that's a great question. I think I have a lot of young patients who insist on coming in every year for their annual physical, and there's actually no guidelines. This might be surprising for people to hear, but there are no clear-cut guidelines on how often you should see your primary care doctor. There's no data that seeing your doctor annually actually decreases mortality. It's really just about having a doctor and having that longitudinal relationship. So, we say every year because of different things. It's good to be able to develop that relationship. So seeing that provider every single year is a way for you to really get to know your provider, and then discuss health screenings. But if you're a 20-year-old with no past medical history, it's probably okay if you're seeing your doctor maybe every 3 years even. On the other hand, if you have chronic medical conditions, then you probably want to see your doctor more frequently. And I would say for my patients with chronic disease, I have them come in every 3 months or so, depending on what's going on. It may be sooner if, if there's something we're actively managing, or if things seem stable, then, can be longer than that. So it's a big range, but has a lot of factors, what you prefer, what your doctor recommends.
It's sort of like in the category of myths. I think about vitamins the same way. It's like people feel like they ought to be taking a vitamin. People feel like they ought to be seeing their doctor every year.
Yeah.
And there's no science behind any of that.
Yeah, there's no science behind it, but it's okay. Because again, it is a good opportunity to discuss preventative health services and just sort of get to know your doctor a little bit better.
Yeah, absolutely. I mean, I like it as a check-in to make sure people are exercising and, eating healthy and all that kind of stuff.
Yeah.
So when people see you, like what screening tests do you think about? And how do you sort of think through the whole screening test process?
Yeah, so again, that's going to depend on your age, your medical issues, if you have any. Typically, I would say most primary care doctors are going by the United States Preventative Task Force. And so the USPSTF really does a review of all the literature, weighs the harms and the costs of different tests, and makes recommendations on screening. And that's based, again, on age, if you have any disease and other factors. They actually have an online tool for any patients that are interested, where you can plug in your age, your weight, your height, and some other factors, and they'll list out all the different health screenings you should be having. And what's great is that it is based on evidence, and so they grade their recommendations from A through D. So a grade A recommendation, there's clear benefit for this test, whereas D, a grade D level recommendation probably, shouldn't do. And then there's also a grade I, where there's indeterminate information. There's not enough information to make a recommendation, essentially.
So what are some examples of some things that people should be getting when they come in to see you, even young, healthy people? And maybe what are some examples of stuff that people shouldn't be getting?
Yeah, so should be getting, and it's things like you might not even realize that what we're looking for or asking, but we do things like depression screening, blood pressure screening when you come into the office. We're asking about alcohol use or substance use so that we can counsel you on. You mentioned before getting an idea of how active patients are. And so all of that is something that I think most people should be doing. And then there's age-specific cancer screening. So over a certain age, getting mammograms, colon cancer screening, and so forth, cervical cancer screening. So those are things that are recommended, and again, based on age.
And some of those things even require a little bit of a discussion, right? Like,
correct, yeah.
When do I start mammogram?
Right.
When should I test my prostate?
Right. So I mentioned the United States Preventative Task Force, but there are all sorts of other societies that make slightly different recommendations. And so take breast cancer screening, for example. The United States Preventative Task Force says you can start at the age of 50. The American Cancer Society says 45. American College of Gynecology says you can still start at 40. And so, yes, this is a discussion. And so we do a lot of what's called shared decision making, where we go through the risks and the benefits of starting at, say, 40 versus 50. And we factor in a bunch of other things like family history, patient preferences. So yeah, it's not so straightforward, and definitely is a discussion.
Got it. And then we talked about some other things that people shouldn't be getting. I guess that's both as screening tests, but also, for certain
any test,
illnesses, right?
Yeah. So I think this is a great question. There are definitely, I mentioned before that the USPSTF factors in harms and costs, and this is an important thing to think about. We sometimes forget that there are harms to testing, and those harms can be false positive tests, misdiagnosis, overdiagnosis, and all these things can lead to anxiety. And so it is definitely important to think about potential harms to any test that we're doing. I want people to keep in mind that the tests that we have in medicine are not 100%. We use this idea of pre-test probability. So what the likelihood of your disease is, then we get the test to help us decide whether or not we think that that's what's going on or not. And so we definitely can have false positives. I would say, take, for example, a patient who comes in with cold symptoms and they get a chest x-ray, and the chest x-ray shows a spot. They go for a CAT scan of the chest. The CAT scan shows a small nodule. And then they're sort of now
it's
down
like they
this
get
track.
stopped, right?
Right, it doesn't stop. They're now down this track where they have to get a CAT scan every single year to monitor this nodule. This nodule was not the cause of the cold to begin with, and now you are being exposed to radiation year after year, or worst case scenario, somebody recommends that you get a biopsy of that nodule, and that can lead to further complications, collapse of the lung. And so definitely we need to think about harms. We also need to think about costs. I know it's not a nice thing to think about, but there are finite resources. And so, having all of this unnecessary testing is not great. I think I saw the number, it's estimated about $200 billion are wasted annually on unnecessary testing. And so, when we think about equity in healthcare, these are resources that could be better used. And so probably in the last decade, we've really been trying to focus on what's called high value care. And that's really just providing good care while weighing the costs and the harms of the different tests that we do. There is a large international campaign called Choosing Wisely. I think you're familiar with it. That was originally started by the American Board of Internal Medicine. And it's basically, a campaign to try and reduce waste and overuse in healthcare. And it ties it to medical professionalism. It's sort of pleading to doctors to be the stewards of our healthcare resources. And so they make multiple different recommendations for all specialties, not just primary care, on how to reduce waste in healthcare. So examples may be things like getting an annual EKG for people who have no history of heart disease, have no risk factor for heart disease. That's really not so useful. Or getting back imaging like an X-ray or an MRI for people who have had pain less than 6 weeks. That really doesn't change management. If we get an X-ray or an MRI, it's really the same management for most people who have acute back pain. And so those are some examples. One thing I get a lot from patients that I counsel them on is asking for routine labs. And so for a patient who comes in,
right, come test everything.
Right, a patient who comes in who is there for their annual physical and will say, well, don't I need my routine labs? And there's really no such thing as routine labs. When we decide what labs to order, again, it's based on your age, what medical conditions that you have, what symptoms you're having. And so this idea of just sort of, blood tests because has no science behind it.
Yeah, right. No science and a potential for risk if you find something
Correct.
that turns out to be false.
Right, you have a false positive, elevated something or other, and then that leads to more and more and more testing and anxiety, and that's
right.
something we really need to think about.
Right. I remember reading a study like that once where somebody had they gave people like a false diagnosis of something. And even though it was corrected later on, somewhere in the back of their mind was still this anxiety about maybe that was the right thing and the correction was wrong. And so there are some of those bells that you can't unring once you flag them. So, all right. So last question. So we've talked so much about, primary care, and some of it, the science keeps evolving, but the sort of style of it is a lot like it's been for years and years. I mean, what do you see are like the big changes that have happened, and what are the big changes sort of coming down the pike that we need to be on the lookout for?
Yeah, I think definitely the pure doctor patient visit has definitely changed. It's less about just the doctor and the patient, and now we've moved more towards what's called team-based care. And so there's a number of other people involved in the team that are helping take care of a patient's healthcare needs, and that includes our medical assistants, our nurses. We now have care managers that, for people who have chronic disease, we'll touch base with them periodically. We have clinical pharmacists embedded. We have behavioral health specialists that are embedded within primary care. And so it's definitely more of a team-based approach now. And I think that might be something that's jarring for patients who are not used to it because there's so many people involved. But, I think it's a plus. The more people you have overseeing your care, the better. And they're all coordinating with each other to make sure that you're getting the best care. And so that's definitely one change that's happened. And now, again, we sort of fast forwarded through the pandemic. We were slowly getting there, but the pandemic really pushed us into this whole world of telemedicine, where, you don't necessarily have to come into the office for a visit. You can do it over video. We do telephonic calls with patients, and we're exploring different technologies to help us monitor people from home. So GMA has a program called remote patient monitoring, where we set you up with a blood pressure machine that communicates with our electronic medical record system. So every time you check your blood pressure, we get that number and we can help manage blood pressure, continuously without you having to actually come into the office.
Right. I mean, I think that's so true that so much that even if the doctor patient, two of us in the exam room thing is sort of the same, so much of what happens outside of the exam room when people are talking to the certified diabetes educator or to the pharmacist or getting their blood pressure monitored at home or having a case manager make sure they're optimizing all the resources they get. And so, I mean, it certainly changes the nature of the visit a little bit because all this other world is sort of happening behind the scenes a little bit. But I think that means that the nature of the kind of primary care job and the way primary care visits get reimbursed and all that needs to change to adjust to that, right?
For sure. I mean, I think, one of the biggest changes I would love to see in policy in terms of primary care is reimbursement. So much of what we do is not measurable. And again, it's about forming that relationship. We do a lot of counseling. And so not a lot of that can be captured in the way current reimbursement systems are structured. And so I completely agree. That's one of the biggest changes that needs to come.
Right. I mean, we have to find a way to make sure that, I think you said this to me before, like the smaller panel sizes, more time per patient and more time to kind of quarterback the care, even for patients who aren't in the exam room. That's sort of where all the excitement happens.
Right. Again, a lot of what we do, that shared decision making, that takes time. And so having 15 minutes to spend with a person that you really want to develop a relationship with, a longitudinal relationship with, is just not enough. And yeah, I think if we really want to take care of our population and our community well, then we definitely need more time to spend with them.
Yeah. All right. Well, that sounds like a good place to end. I mean, I could talk about this all day, and I think you probably could too.
Sure.
But I'm going to let you get back to seeing patients, and we're going to let everybody else get back. But I thank you so much for joining us and having this conversation with us.
Thank you again for having me.